is there's going to be a voluntary admission where the person has capacity to make that decision to be admitted to the hospital and have essentially they are involved, in the care plan. I acknowledge these situations can be very traumatic for people, and they're not decisions that we take lightly because you're taking someone's free will away. It's a huge thing, huge responsibility.
Hello and welcome to Bipolar Talk, the space to discuss all things bipolarity. I'm Clément Bessard, the founder of Upstage, and our mission is to transform our bipolarity into an opportunity. We're lucky to welcome Dr. Lieu-Chi Nguyen today to talk about human-centered approach in psychiatry for inpatient care in Sydney to remote Aboriginal community, and what it means to see patient as a whole people and not just diagnosis. And I'd just like to present yourself here.
Hi, Clement. Thank you so much for having me on this podcast. I was really flattered, actually, when you reached out to me on LinkedIn. Yeah, so my name's Lieu-Chi, or my professional name would be Dr. Lieu-Chi Nguyen. I am a predominantly public sector psychiatrist. I'm based up in far north Queensland, specifically in Cairns. I've covered a various kind of bunch of roles, such as, within the private sector as well as, the public. But I think the public sector is something I always kind of come back to. Yeah, I've mainly lived in regional Australia for most of my adult life. And I think kind of access to care for those in the regions, is something that I'm really passionate about. But yeah. And I guess I see those with bipolar affective disorder as part of a generalist psychiatrist kind of practice.
Yeah, I think it's really interesting to understand a little bit how the public sector works. Because if you put myself in my situation, which is like an immigrant who have been there for 3 months in Australia, I wonder how does it work? And how do you get cares and where to ask? Simple question, actually.
Yeah, sure. So I think it's a little bit different in different states. I've worked across kind of generally locum capacities and kind of, as a permanent staff member on the team. So I've worked across states such as New South Wales, the Northern Territory and Queensland. So unfortunately, I can only really speak for those states. Actually, I've worked in South Australia as well, very, very briefly. So I can only speak for those states, but generally the public sector deals with kind of moderate to severe severity when it comes to any kind of mental illness. We deal with a lot of crisis presentations as well. So when people's lives are at risk or the lives of others are at risk as a secondary kind of, secondary to a mental health crisis or kind of having a relapse or a first presentation of kind of mental illness. In terms of access, there are crisis mental health lines that most often people can go to. So often it's very catchily done, such as it's 1300 mental health call is certainly the one that is in Queensland, kind of certainly accessing organisations such as, Beyond Blue, they'll have, or Lifeline, they'll have kind of, emergency access. And if it's something that, it needs to be managed beyond the confines of a crisis phone call, then usually the advice is to call kind of 000, which is the Australian kind of emergency services line, and often kind of presentation to emergency services after that. Yeah, so I guess that's the gist of access. It's usually kind of very, very acute kind of presentations. Once you're in the sector though, there's different kind of streams of care that people will get. So I guess when you look at a website for a kind of public mental health service, a public community mental health service, can be really confusing, hey, because you've got all these different names, you're who's behind it, who's different teams. But generally in my head, I think about as inpatient care for when you really, really need it, when people need often kind of safety containment. And then there's acute care teams, or in other states, they're called CAT teams, or crisis and triage teams. And they look at kind of really kind of acute presentations and make decisions as where to get ongoing care. And particularly those with kind of severe or complex mental illness, of which bipolar can be, then, there are continuing kind of care teams that look after people too. So they're the usual community teams. Kind of a lot of my life so far as a psychiatrist and as a trainee in psychiatry, I've been kind of in a community care team. So my goal is to, a lot of it is kind of helping people understand what, their illness is, kind of getting them on the right treatment package, whatever that might entail, getting in the right supports. And the aim is to eventually get people back, to GP care or kind of potentially like private care. So we kind of want to step down, to that care so that we can then give it to other people. The other end of the spectrum is that, when someone is getting unwell, for instance, then kind of preventing hospitalization as much as possible, but then kind of guiding people to hospitalization if that is where kind of, the care is needed. Yeah, that's like, I guess, an overview of what happens. Most likely within the public mental health system, you're going to come into contact with someone who is a triage person, like usually a mental health nurse. Like that would probably be the first point of contact. And I guess, for someone who's accessing that care, like I wouldn't think too much on kind of, what you're trying to help us, I suppose. Like just say what your issues are, and then we'll try and help you kind of get on your way.
Yeah, so like calling the numbers, then usually seeing a nurse who's going to help you figure out where to go. And then depending on your need, like you can go to hospital, or you can go maybe to like, I don't know, you can have meetings, because like in France, it's really complex. It's a lot of different key players. And I think it's really important, like, because I'm asking myself the question. So I'm bipolar myself, and I'm stable for many years now, but you never know. That's a sad story, is like you can always relapse and you always have to be careful. And I prefer to be like to know what to do if it happens. And
Yeah.
so basically, yeah, so number, the nurses, and then how does it work? Like you can, when you get hospitalized, how does it go? Are you reimbursed or not? Or how does it work?
Yeah, sure. So within Australia, there's like, so if this is rusty, but perhaps like, I suggest getting someone who works in kind of health finance, like perhaps one of the people you speak to next time. But so in general, if you're an Australian citizen or if you've got permanent residency, you have access to Medicare. In public hospitals in Australia, you pay nothing. In certain states, like, maybe you'll have to pay a fee for the ambulance, but often that's waived actually, when someone gets admitted. Otherwise it's completely, it's completely free. I think more from my end, I guess, like kind of, my concerns for admission, for a patient, depending on how unwell I guess they are, then the question then would be, is this going to be a voluntary admission where like, the person has capacity to make that decision to be admitted to the hospital and have essentially like they are involved, in the care plan to the utmost degree, or is it going to be an involuntary admission, which is mean that these acknowledge these situations can be very traumatic for people, and they're not decisions that we take lightly, because you're taking someone's free will away, which is a huge thing, huge responsibility. So if someone comes in involuntarily, it means that they reach a level of concern where, like, yes, within different criteria, but they generally it means that they are, at risk of harm, significant harm to themselves or other people, like in the throes of the mental illness. And one of the fact clauses for most states in Australia is that they do not have capacity to manage their mental illness. So then then they would be admitted as involuntarily. There are some in between potentially, and I think it particularly pertains to people with bipolar disorder, because for a lot of the people I see, like, the illness is episodic. So kind of when you're well, you're really, really well, and when you're unwell, like, potentially can be very unwell. There are like steps in between, which I haven't seen that happen all that much, but something like having an advanced healthcare directive, so that you yourself are giving instructions to the healthcare professionals when you are unwell, that also works. And also kind of having someone that you trust, so having a health kind of enduring, like, power of attorney is like really useful too. And those are like kind of the in-between steps where, like, you're still giving yourself instructions, even if you're at that point in time you're so unwell that you cannot, you don't have capacity to manage that, your condition. I don't know if that answers the question, but yeah, a little bit of that. Once you're admitted, I guess you will get treatment very regularly from a team of, say, nurses, allied health. So often mental health units will have an occupational therapist or a psychologist, for instance. And then, usually there's a psychiatrist, and there's also a trainer that kind of, is on the team too. So yeah, they'll provide you care, or see you very often, kind of potentially give you medication, or, kind of there's sometimes, there's often kind of, groups and things like, maybe yoga or something like that. Just because if you're in hospital, it can be potentially quite dull. It can be quite traumatic, in the sense that there are other people who are also very unwell. conversely, what can be useful is that, there are other people who are in the same boat as you, and there's like potentially some camaraderie, with that. And then, once, things are well enough, people don't have to be 100% well, and that can be I guess that can be a factor that we discuss with kind of, the person, and also their carers and family, and, their support people, because that's a really, really important part of like, the care team are the people who are around, kind of the person 90% of the time, like, whereas healthcare professionals are there like, 1 to 10% of the time, right? Kind of you as the person know yourself best. You and, the people around you, they know you more better than any of us put together. So, kind of once as a decision, it's, it's like you can be managed at home. Things are like, things are going well there. You get follow up with the community teams I briefly mentioned before. Then you're discharged. In the public sector, like we're often understaffed, kind of underfunded, right? We try to get people out, in the community safely as much as, as soon as possible. Because, no, I think, anyone really likes to be in hospital. I could be wrong. Like hospital can be useful for people. People can find it very safe and containing. But most people would rather be living their lives. Hey, so yeah, that's a little bit about outline of what. Yeah.
Yeah, and I think you're right. Is like I feel like preparing ourselves is the most important thing. And if you're listening right now, and what I did is like to really write down like what do I want to happen? Like how do I want to happen? Because you never know. But just preparing yourself, like knowing like who do you want to go to the hospital with? Who do you trust to take decision if something happens? Where do you go? How do you want to do it? And even I've like sometimes even the contact of your current psychiatrist, the treatment that you take, all this type of information is really helpful because it's like maybe you never have to use it, and I hope so. But if it happened, it can change a lot of things. Because sometimes when we are in apomanic phase or manic phase, we are saying things that can hurt people. And of course, the professional are here to help us, but you never know what can happen. And I heard a lot of story where things go wrong, I have to say. And then it's like, it's a mess. So just preparing for like sometimes a few minutes can like help you save a lot of like energy. And so one of the things also I wanted to go deep in is like, so you have the hospital, which is really important, but that's after the hospitalization is also when the work continue. And how does it work in the public sector? Because do you have like some time of like day hospital, or do you have some time of like help from just cabinets? So I'm giving you an example. Like in France, we have something called CMP. So it's basically a place where we can go, and we usually have like psychologists, psychiatrists, and nurse to help us. But it's mainly like maybe once a week or once a month, you go there and it's free and you get help so you don't relapse. So do you have this type of thing?
Sure, that's a really great question. I agree with all the things that you've mentioned to your listeners as well, like in terms of kind of for having a bit of a safety plan. And I'd like to add a little bit to that, in that. So websites such as Beyond Blue and Sane Australia have something called a safety plan. So this is something that, is it done with your usual kind of, treating team, whether it's public, private, you yourself doing it with the, kind of with that GP, for instance. There are safety plans. And in addition to the things that you've mentioned, such as those in your treatment team, such as psychologists, psychiatrists, there's also things that you can do yourself. So even that's really useful for us. Like if on there it says kind of, when I'm really stressed, I respond to classical music by Mozart, because we know when kind of you talked about kind of the throes of mania, kind of we know if even then, like you still keep that core of yourself, right? So like playing music through headphones or something while you're in this really distressing environment potentially can be really useful. I think the other side of this for those with bipolar is that it's not just mania that can be dangerous. It's also kind of, people can get very severe, difficult to treat depression, and kind of where people don't eat, they don't sleep, kind of they find it very hard to move out of bed, for instance. So that in itself can cause danger, to the point where like if there's like self-neglect or kind of physical decompensation secondary to that. So I'd like to, I guess, add that to your second question regarding like what community supports out there, whether there's like step down and things. There are. So I can really only Actually, I can speak to Queensland and New South Wales, like from my own personal experience. So there are things called kind of mental health rehabilitation facilities. I can't speak to how long the waiting lists are or the availability, and like anything in the public sector, it often is quite variable. But those are places where people kind of, they are either when they're relapsing, for instance, and they need that extra support, they can step up into that level of care. And then there's also like after hospitalization, like kind of people can step down into that level of care as well. So, for instance, there's long-term kind of mental health rehabilitation, and there's short-term mental health rehabilitation. So the more short-term ones can be anything from a week to kind of 4 weeks, let's say, and then longer term ones might be kind of 3 months to 6 months. So the longer ones, for instance, if someone is functionally kind of quite has deteriorated a lot because of their illness, it might be a good time to put in support, such as through the National Disability Insurance Scheme, as an example, or kind of setting up community supports, kind of contacting them to the local kind of community mental health team. So I guess that's talking about rehabilitation, which in a way is its own admission. Like, you're staying there overnight, that kind of thing. A further step down from that would probably be one of two options. So, A would be maybe ongoing follow-up with, say, the acute care team or crisis triage team. And so, like, they can make decisions within, like, say, 2 weeks or so, or some places up to 6 weeks. Kind of, regarding your next move. So for some people, kind of, after being in hospital, follow up with GP is fine, kind of with maybe the occasional psychiatrist kind of input. Whereas others probably need, more in-depth care, such as like with a continuing community team. And in that situation, these people would probably be followed up, with a maybe mental health nurse or a case manager, who doesn't necessarily have to be nursing. They can be kind of social workers or occupational therapists, as an example. Follow up maybe kind of, once every few weeks or so, if things are going well, maybe even once every month. And a psychiatry appointment kind of maybe every 1 month to kind of every 3 months. Generally, it's a clinical decision. Like, let's say if I'm seeing someone and I'm a bit worried about them, they're not as well as possible, or they've just come out of hospital, or we know things are really, really stressful that are about to happen. Like, they go through a breakup, or kind of they go through court process, things like that. I might see someone more often if I've got capacity for it. So yeah, I don't think that's kind of helpful, I suppose. The other thing is in terms of how long we kind of manage someone under kind of these systems. So often, like, we review that decision, say in the community team would probably review it every 3 months, whether someone needs kind of, ongoing care. And we discuss that as a team. So in public sector mental health, like, there's the multidisciplinary team, which means that as kind of, there's doctors, there's nurses, there's like, psychologists, like social workers, we speak as a team and kind of optimize people's care, because we know that kind of 10 heads are better than one head, and we've all got blind spots, so yeah. So that was a lot of information. Yeah. Very quick succession.
No, but I think it's really important what you're saying is like that. Of course, the hospitalization and when it goes wrong, of course you're going to be helped, but it's what you're going to do after it. And I always say that for us, the window of opportunity is usually like when we are quite stable, I would say. Yeah. Because that's where we do the main change, and when we make the right decision to build this stability. And we can talk about rehabilitation, but I use stability because everybody knows.
Well, yeah.
So, and I feel like it's exactly that. It's about building your team and asking for help. And you can do it with the public sector. You can do it with the private sector. Mm-hmm. And that's one of the things also I'm wondering, and like, how do you choose where to go? Like public, private, because it's really like, at least, how does it work? I think it's a question we all ask ourselves, and we all want the public sector to be great, but sometimes in some places okay. So it's a tough question, but you know what I mean.
Exactly what you mean. I would say that, when we think of the public sector, we think of two main reasons why someone might access it. So I've talked about hospitalization, and including involuntary hospitalization or involuntary admissions, as we call it. That would be one kind of reason why someone would be in a public sector rather than a private sector, because nowhere else generally in Australia, can you be hospitalized, when things are so kind of dangerous that you need an involuntary admission. So we're going to, like, in the public sector, it's always going to be like very acute kind of, so we've got quote unquote like pointy end kind of, end of psychiatry. We also kind of come in touch with other sectors, such as, say, forensic systems. So if someone is incarcerated and they are very unwell, then that would go to the public sector as well. There wouldn't be capacity for that within the private sector. So that's one point of decision making, is the kind of level of acuity, right? The other point is access. So if you can't afford a private kind of admission, and you don't have capacity to access kind of private health insurance, which then unfortunately rules out that kind of private access, then you're left with the public sector. And I think kind of, that's, sometimes people kind of talk about how long the wait times are, or, kind of, how acute the others around you are when you're getting treatment. And I think that's partially why, is because at the end of the day, the public sector we're always going to be there. We have to be there. Like, kind of that's really, if when dire circumstances happen, that's why the role of the public sector. So we will see anyone. If you can't afford kind of healthcare anywhere else, like we will see you. But obviously with that comes with its kind of resource management. And sometimes we're just left with managing very, kind of people who are getting quite unwell, I suppose, rather than trying to do a lot of prevention, because we just have to kind of look at where the skills are kind of, desperately needed, I suppose. Yeah. So so that makes a little bit of that decision making, like, is taken away from people, because, the public sector only deals generally deals with like these issues. Generally, if people can afford private healthcare, I'm not saying kind of one is better than the other. I think kind of within Australia, as we stand, like, they are part of the health ecosystem. If people can access the private sector, it means they've got, choice with kind of who their psychiatrist is, for instance. They've got kind of, it's a bit nicer, maybe, like in terms of the environment and in terms of potentially the food, if you are to be admitted. If you kind of don't need a public sector admission, often private sector has groups. So there's group therapy, which can be done on the site of kind of the hospital, which is quite good for people who, kind of want that community as well. Yeah.
Quick break. Can you let us a review on Apple Podcasts or the platform of your choice? It really helps us break the stigma around bipolarity. Let's get back to the episode.
Yeah, and I feel like it's always the same thing. Like, if we cannot afford it, that's one thing, but we always can do things ourselves, which is like free to help us not be in this situation. And of course, I wish to be in a world where everything will be funded properly and there won't be waiting time. And I actually believe that it will be cheaper, because then we won't have the difficult cases, and then people won't get hospitalized as much. But that's one thing. Like, we tried in the past to pass a law in France and everything, but it's like so much work. To be honest, I don't want to do it again.
Yeah.
But one thing you say is, how can we manage not to be in those extreme cases? There's hope, there's possibility. And how do you find, for example, and for myself, it was a friend who became a peer helper, and we're doing friendship peer helping all the time, like every week. And that's the type of thing everybody can build, and it's not costly. It's just like, and maybe it's someone you met at the hospital, maybe it's someone you met, I don't know, in the community, like Upstage or someone else. But what I mean is, just building your system is the best way. And the public sector is to help you do it. The private sector can also help you. But at the end of the day, is your system, is yourself, ourselves as Bipolar can build what we need to basically find a way to prevent relapse and everything. So one thing you also talk about is, like, there's many different people who can help us. You have the nurses, you have the case manager, but what are their job? What do they do? And when do we contact them? How do we how do we know what's the right person for us?
Yeah, sure. So within the public, I guess within the public sector, you would have a case manager who can be, a nurse, they can be a social worker, they can be, a psychologist. Like within a team, like the MDT or multidisciplinary team kind of setting that we spoke about, we do make those considerations, right? Like if we think someone needs kind of maybe a bit of therapy, like, in the early parts of like kind of their treatment, as an example, like, so they lots of psychoeducation, kind of there's someone who we need to be more in touch with kind of what their moods feel like, for instance, like, maybe like some cognitive behavioral therapy as an example, then a psychologist would be fantastic as a case manager. If someone like is, kind of they're struggling with their medications, whether it's acceptance with it, whether there's like maybe side effects, kind of there's potentially lots of rapid changes in medication through the psychiatrist or kind of trainee, in order to kind of, manage moods as an example. And maybe a nurse would be kind of, more of a good kind of case manager. We say that this is kind of, optimal, real, optimal fantasy world kind of considerations. Sometimes it's just whoever's got capacity, I guess, to take on board with the new the new person. But kind of we do make those decisions. So in a way, like for the for the person, it might be a little bit hard to make those decisions, but they can certainly raise what they want, which I think kind of comes to you're answering your next point around what is it that the person can do. Like there's a lot that you can do. You are with yourself 100% of the time, and I think kind of part of interaction with the health professionals though is like, let us know what's going on. Please us. If you don't think you have the diagnosis or whatever it is, like your doubts, like please tell us, because we like you're a good, decent clinician shouldn't be dismissing you, like they should be taking those concerns into account. And, and I think that's part of I guess the journey, I suppose, as sometimes people talk about it, is learning more about the condition, rumbling through the difficulties, people can dissent. Like you can, like if you think what we're saying is rubbish, kind of tell us. And we'll probably kind of explain like where we're coming from. And if we just all have this conversation, I think like we come to a better place, even if we disagree with each other. At least like it's all in the open, and we're aware of like what your concerns are, and you're aware of what our concerns are. I don't know if that answers the question.
Yeah, no, but I think like, so case managers, so because there's many people who can help us.
Yes,
and
that's
so
right.
the most important for me at least is to be able to ask for help, which is not something that we learn as much as we should. Is like, we need help with bipolar. That's how we're gonna basically make it work. And so if we accept that, and we accept that we can ask help, and people will like to help us, that's something that I switched my mind many years ago, but that understanding that people love when you ask for help, because they're happy to help you. It can be like people you trust, it could be your family, but it's also professional. That's, I would say, my superpower now as bipolar is like asking for help. And so, can you tell us a bit more, like, because the case manager is a key role to help you, and what do we do on a day-to-day basis?
Oh, sure. So within the team that is looking after you, I'm gonna just put us in the community setting now, because I think it's where most people within the public sector probably would be in. What we'd like most people in the public sector to be in is being, at home, living your lives, that kind of thing. Like, depending on how kind of often you're seeing the case manager, they'd be the primary point of contact, to the team looking after you. And then, like most people will probably have a way to access them. Like, so some case managers might have like a work mobile, for instance. So in between, I guess, appointment, if things aren't going well, like if there's any concerns or any random questions, like just ask. Just ask. If you need, I guess, like more time, just ask for it. Because we don't know, we can't mind read. I wouldn't want to mind read. It sounds very stressful. If we can't mind read, so if you're struggling, definitely if you're struggling, let us know. If you've just got queries, let us know. I say ask because I'm also part of that team, and I probably see the person less than the kind of case manager, for instance, but I'm still there. So like if for instance, I'm always open to people asking me like all sorts of things, even if it's irrelevant to let's say they're coming in with like bipolar, which is the whole point of this podcast. But if they want to ask like something kind of off topic, like nutrition or like, kind of neurodivergence or something like that, just ask. Like I might not know the answer, and I'm pretty open with telling people not what I don't know, but like, it can always lead you to resources, can lead you to someone that we're aware of. And an example, for instance, is if someone's thinking of kind of, having a baby or something, you let us know, like all of this stuff we want you to know. And like we really don't want to happen, which can happen, is that kind of people making changes to their treatment plan without telling us, because they've got other concerns which haven't been raised. So, very often, like people might go off, kind of say their treatment, whether it's medication, whether it's attending appointments, that kind of thing, because say they're pregnant and they kind of, they're really stressed about that, or they're attending a court case because it's something to do with, maybe it's something to do with what happened when they had mania. It's like that stuff we can help with. We can help you navigate that, kind of potentially navigate that forensic system. It doesn't guarantee anything. It's not, I can't guarantee that there's going to be a particular result or anything like that. But, we can link you in with the right people.
Yeah, it's really the most important thing. And like, even I myself, of course, I'm questioned by my meds. Sometimes, like, I remember the conversation I had with my psychiatrist. It's like, oh, should we like have more quantity? So it's like, sometimes it's a lot about quantity. Sometimes like, it's not your meds that is not working. Maybe you're not taking the right quantity. Maybe you're not taking it at the right time. And most of the time, just talking about it and saying, hey, it doesn't work for me. I have secondary effect I don't want to live with. And then we'll find solution. And it's great. Like the case manager is like kind of your, I would say, the one who know all the team and whose job is to find you the right person and put you in touch with the right person at the right time. And it's really easy, and it's like your entry point, I will say.
Yes.
And of course, you can contact everyone in your team, but it's like, and I feel it's really important to be able to connect and know. So that is a key part of your like stability, I would say. And then there's other people around. I really want, because I really believe that we need a team, and everybody has a different need of a team. My team personally is like peer helper, psychologist, and psychiatrist. And everybody has his role, and it's how it works. And of course, I have my girlfriend, I have my mom, but it's like my main team, I would say, are those five. It's like, and how do you build your team, and which person in the team is going to be like the right one for you? So in a public sector team, you have the case manager, and who else? What are their role and how can they help you? I think it's really important for us to understand.
Sure. Clement, you sound like you have a fantastic team that you've built over the years. Like, I'm really happy to hear that for you. I am hesitant to give a direct answer as opposed to, not direct, but I really kind of concrete or rigid answer to that, because I think like, public sector or community teams are variable, like depending on kind of, what health professionals are available. But often there would be a case manager. The case manager is kind of at either allied health, so we're talking about occupational therapists or psychologists, or a nurse. So whether that's in they're their key contact, as you said. So no matter what their background is, like they're, kind of, I guess that part of their role certainly is to, coordinate things. So making sure you attend appointments, kind of, being aware of like what other supports you have. Like, let's say you've got a private psychologist out there who kind of helps you build skills to kind of manage your moods, to kind of, maybe align you to the goals and, the life that you want, right? Using kind of sometimes from dialectical behavioral therapy there. But they can help you with that. And like the case manager is like this coordination point, I suppose. Then you've got your psychiatrist, who mainly, like, the classic thing is that we kind of want to like look at your medications and potentially like, kind of any neurostimulation modalities that people might also need. The other thing I think that's really important in, psychiatry is like having that kind of, overall like, bird's eye view of, kind of what's happening. I think that's, part of our role is like looking at kind of, what is this the right diagnosis? Is this the right treatment plan? Is there anything missing? Like, are there holes in the treatment plan? Do we need to like coordinate someone else like with your care? So that's like, I think that's actually really, really part of like a really big part of kind of being a psychiatrist. So like that's where the psychiatrist comes in. You mentioned peer kind of, workers. That's really awesome. Like, I worked in teams where there is a peer support worker, and they can help you, I guess, like have that, lived experience or living experience kind of aspect, to your care. So they've been there, they've been in your shoes, like to some degree, and they can maybe help you, I guess, like come to accept the diagnosis, to understand the diagnosis, or potentially like reframe it. You're saying like, look, I don't think you're at the right place where you're accepting the diagnosis, but can we maybe draw some analogies which might be useful for you, such as, like, let's think of this as a, kind of like, let's think of it as like diabetes, if that's something that you kind of struggle with. Is it something that we just have to manage? Yeah, I think those are the ones that, kind of cut at the top of my head. That's within the kind of mental health multidisciplinary team. There's also GPs. So like, we're talking about kind of psychiatric conditions here, right? But but a lot of us, we also have like health concerns. So whether it's just like a cough or cold, like once a year, or you've like gone and sprained your ankle or broken a leg because like you're into mountain biking, I don't know, whatever the life you want to live. The GP is also part of it. And like usually kind of, the psychiatrist, like, kind of would be communicating with the GP or the case manager too. So like, so they're part of your team also, like outside just kind of mental health. Because I mean, as much as we speak about mental health as if it's something separate from physical health, like we're all kind of one organism. And like we have within the systems that we kind of live in, like in terms of government or healthcare systems, we sometimes silo too much, but really we're just one person. Yeah, and like kind of being aware of that is, I guess, like a good point to have. So yeah.
Yeah, I will try to add a little bit on that, because like, so you have your nurse, case managers / psychologists, psychiatrists for the treatment and diagnosis, GP for like basically health related. But then sometimes you have psychologists, and sometimes, so can you tell us about like what is the role of the psychologist within the team also?
Yeah, sure. So I guess it can be a bit confusing within the multidisciplinary team, because sometimes that's like, even though they're a psychologist, like in their terms of their qualifications or their background, they're operating as a case manager. So they might not necessarily be doing therapy with you. Some do, like some might use that case management as an opportunity, to kind of provide some therapy, which is awesome, like, which is kind of really, really good. But but hypothetically, let's say you have a private psychologist, let's say, right? So, and that's who you see in addition to, at this point in time, you need kind of your assistance from the public mental health team too. I'd say, like, hypothetically, we're just going to move you to the private psychologist. We'll bring them in here and talk about them. So I guess it's psychologists, generally, they deal with what we call as like talk therapy within the clinical setting. So using kind of communication and talk to help you, kind of manage, kind of say, moods and, behavior. So usually that can be done through various kind of modalities. There's different types of therapy. At the end of the day, it's talking and kind of, sitting with your emotions and, things like that. So there's that. So particularly for those with bipolar affective disorder, something called, I know let's get this one, it's like interpersonal and social rhythms therapy. So looking at kind of, how to, kind of regulate your moods, like using kind of, I don't know, you've probably done this yourself, so you can probably explain it so much better than I can. But, using strategies to, like, notice your moods and kind of doing things, that help with it. So I'm going to tell you about a story. So I came across like this type of therapy without even knowing it was this type of therapy. When I was in high school, there was a person who had a lived experience of bipolar, and she came to our high school and spoke about, kind of her condition and how she manages it. And she talked about how when she's feeling like she's elevating, she'll do kind of, calming things, like she'll sit on the couch and maybe watch like TV or kind of do some meditation or have aromatherapy. And when she was, feeling low, she kind of did the opposite. She actually moved herself more. So she might go out for a run or something like that. And like my understanding is that that's part of, kind of interpersonal and social, and social rhythms therapy. So the other things like looking at kind of relationships and how, kind of interpersonally, kind of what we're doing and like other things that we can, do better, kind of noticing things that we might be kind of prejudging about people, as an example. And kind of challenging those thoughts. That's my understanding of kind of what that particular type of therapy is. But I mean, like, something like cognitive behavioral therapy would be also really useful for someone with bipolar disorder, just to be aware that, this relationship between thinking, behavior, and, kind of feelings or emotions. And just because the more understanding we have about our, conditions and how our mood are, that isn't just for people with bipolar, it's for all of us. And like the more that we have better understanding, the more that we can, start to make changes to live the life that we want to. So that's what the therapist is. I guess that's the therapist's role, is kind of to help you, or psychologists actually, I should be saying, is to help you, I guess, like build those strategies, be aware of yourself, like your own mood kind of rhythms, and giving you the strategies to live the life you want, maybe in spite of those kind of mood challenges, or now with the improved like mood challenges. Does that answer the question? I feel like I just rambled for a bit.
No, it's like I think it's important because it helps us to understand a bit more deeply, like what's going on, who is doing what roles, and for us, it's really about like how do you build your team, and sometimes you will need maybe to have someone from the private sector with someone with the public sector, and those two things are not against each other. It really could be complementary, and I feel it's really important to say that, because it's not like one is good, the other one is bad. It's really like depending on your situation, depending on how much money you have, depending on what you need as a care, and how you can build this for yourself. So I think it's really interesting. I have this one last question, Liu. Is like, if you had a magic wand, what would you change in mental health?
Sure. I like to go back to the previous question just really briefly, if that's okay. So I would actually think of kind of public and private as maybe waves that are kind of simultaneously like working with each other. Sometimes like when maybe things are kind of more stable, I'm going to use your term, like more stable, maybe there's more kind of there's more need for the private sector, and I'll include the GPs in that too. Like there are people out there who can be stable for many years, like on, let's say, a medication and seeing a psychologist like once a month, as an example. That can be, that's great. That's awesome. That's where we want people to be, like in the public sector. So I would think that it's a wave of kind of needing, public sector management. If things are kind of in crisis, for instance, if things are unstable, like that's when, we can, kind of we step in. But once that's done, once things have become like stable again, then by all means, like let's get you back into kind of other teams that probably know you for years and years and years and years, and that's so important. Like that continuity of care. So the magic one question. I've thought a lot about this because I knew it was coming. I mean, I initially was thinking of saying just improving the social determinants of health, which are kind of things like kind of food, shelter, access to clean water, that kind of, like we all need that. That's like bottom rung of like Maslow's hierarchy, right? But I felt like it was a bit of I don't know, like it's just like it seems too magical. Like it seems too kind of, it's too broad. So I would say, well, what's more likely while we still have this magic wand kind of situation happening? I would say in a kind of general situation that most people are in, like kind of not in like say a combat situation, or kind of a refugee, or kind of situation or something like that. I would like to think if we could all just have 1 second, or even like just 1 second of, at least when we're really stressed out, just 1 second of just briefly being able to slow down, stop, and have empathy for the person that we're fighting with, or like having conflict with. Because I think we just have like that moment of insight where we can truly be in someone else's shoes. I think that will actually help with a lot of conflict, because I think most people in the world want to do well. They just want to do well for their friends, their family. They just want to have a good life and live the life they want to. And we're all in this together, right? So we can somehow just have a little bit more care and empathy and compassion for each other. Like it's a second. I think that could make huge changes. So that's the magic wand.
Yeah, thanks a lot. Yeah, so it's great. I think we cover a lot about the public sector and what we can do as patients to basically like find a way around it and find our team and find our stability. So I want to thank you a lot, Liu.
To learn more about bipolarity, go to our website, upstage.com, hopestage.com. See you soon.